So today we are going to discuss a different topic, right? So I think we never discussed this one. So we have discussed something in the MCQ, but it's a common topic and odd topic. But as a obs and gynae students, you need to know this, right? So obviously it's an important topic, right? So the management of premenopausal as well as the postmenopausal cyst. Even though it's a small topic, there are two guidelines in RCOG. There is one guideline for management of ovarian cyst in postmenopausal, and another guideline is management of ovarian cyst in premenopausal women. So I have made a notes on that. So that basically that notes is based on the RCOG guideline as well as the MRCOG evidence-based books, right? So that is the latest evidence. So most of the things I have mentioned. So few things I kept blank. So while we are discussing, right? So you need to write it down, right? So then why I thought that, so people might be interact and you may have to concentrate on the study. So I'm really sorry. So I sent a bit late, so you might not take printout. So anyhow, so I'm another one due to clashing of medicine class. So then students was requesting to change the time. So then I changed the time again. It's clashing with my time. So I don't know. So and also some students might have university lectures in the morning. I know. So I'll give the recording. The students who couldn't attend to the class, I'll give the recording. So the purpose of doing classes, at least you need to know something about this, right? Fine. So the management of premenopausal as well as the postmenopausal women. So first ovarian cyst. First we'll discuss about the postmenopausal one, then we'll come to the premenopausal one, right? Fine. So in regarding ovarian cyst, right? So the ovarian cyst also, as we know, first before we discuss about the ovarian cyst or ovarian pathology, first we need to know about something about the ovarian anatomy as well as the histology, right? So when you see the simple anatomy of this ovary, right? So this is your uterus here. We know this is the ovarian ligament, and our ovary is here. The ovary is attached to the lateral pelvic wall by the infundibulopelvic ligament. Infundibulopelvic ligament, right? So at the same time, as we know, the fallopian tube. The fallopian tube is here, right? So this is the normal anatomy, right? So when you see the ovary is attached to the uterus by the ovarian ligament, and the ovary is attached to the lateral pelvic wall by the infundibulopelvic ligament, right? Fine. So here, when you see the histology of the ovary, when you see the ovary, so the ovary can be divided into two. One is cortex, another one is medulla, right? One is cortex and the center part is medulla. So when you see the cortex, right? So the cortex is lined by the ovarian epithelium, right? This ovarian cortex is lined by the epithelial cells. That is called ovarian epithelium, right? Sorry. Give me. Right. So once you see the ovary, the outer part is the ovarian epithelium, right? So the ovarian epithelium and your cortex and the medulla. So please try to understand, right? So then it's easy. So if you see the ovarian cortex, right? So ovarian cortex, if you see the ovarian cortex, right? If you see the ovarian cortex, in the ovarian cortex, as we know, there are so many follicles: primordial follicles, primary follicles, secondary follicle, Graafian follicles, right? So Graafian follicles like that. So there are so many follicles in the ovarian cortex. So basically, the ovarian cortex has germ, right? The ovarian cortex has germ cells, basically germ cells. Not only germ cells, also it has other cells, but mainly it has germ cells. In addition to that, right? So your medulla has blood vessels, right? The medulla has blood vessels, which is supplied to the ovarian tissue. Blood vessels, veins, nerves, right? Right. So the medulla mainly having the blood vessels, nerves, and other connective tissue. So in between these uh, germ cells as well as the blood vessels, you are having the connective tissue. Right. Right. So in between the blood vessels as well as the germ cells, you are having the connective tissue. Right. So the fibrous tissue. So what is the significance of knowing this is, yes, I have muted, yes. What is the significance of knowing this is, one, right? So as we know the histology of the ovary, right? So it's a bit of difficult, please try to understand. So the histology of ovary, when you see, there are so many type of cells. The epithelial cells, even in the epithelial cell, you are having different type of cells. You are having germ cells, right? You are having germ cells. The germ cells are primordial follicle, primary follicle, secondary follicle, tertiary follicle, different type of germ cells, right? So in between, you can have some kind of fibrous tissue like a granulosa cell, right? So theca cells, fibrous cells, right? So blood vessels, right? Hemangioma. So there are different type of cells. So what is the significance of having this different type of cells is, you can have abnormal proliferation, or you can have malignant transformation in these every type of cells. Do you understand what I'm telling? So you can have malignant transformation in the primordial cells. You can have malignant transformation in the epithelial cells. You can have malignant transformation in the blood cells, hemangioma. You can have a malignant transformation in the granulosa cells. You can have malignant transformation in the fibrous tissue, fibroma. So as we have different type of cells, each and every cells might have chance to develop malignant transformation, or even you can have a chance to have a benign tumors. So it means there will be a excessive cell proliferation. There will be a excessive cell proliferation. It could be a benign or malignant. It could be a benign or malignant. So benign or malignant. Right now, this proliferation can be in different type. One, it can be a tumor proliferation. So solid proliferation. What do you understand by solid proliferation? The cells are proliferating, and it's completely solid material, solid mass, right? Or sometime you can have cystic mass. What do you understand by cystic mass? So there is a capsule covering. Inside the capsule, you are having the fluid collection that is called cyst, right? So your proliferation, so tumors can be a solidic or cystic. Solidic means solid proliferation. Cystic means fluid collection inside the capsule, right? So if you see the ovary, there might be a capsule. This capsule is here, right? Inside the capsule, you can have the fluid collection. This is fluid collection. This is called ovarian cyst. This is called ovarian cyst. Sometime along with this cyst, you can have some solid component as well. So this is called cystic and solidic nature. So now I have told you in 3 ways. One, it could be a solid mass, it could be a cystic mass, or it could be a cystic with solid component. Right. What is the significance of knowing this cystic, solidic, and cystic and solid nature is, right? So the cystic nature or fluid collection inside the ovarian capsule, it's most likely to be a benign. It's most likely to be a benign. But if it is a solidic component or solid mass, it's most likely to be a malignant. When it is converted to malignant transformation or malignancy, then you will have a solid component. So having a solid component into the cyst or having a solid mass into the ovary, it's high likely to be a malignant. So if it is a simple solid or cystic, then it's high likely to be a benign lesion. It's going to be a benign lesion. Right? Understand? Right. So when you see this ovary, right, during the ovulation, during the ovum development, right, you can see the primary follicles will convert to primordial follicle. Then primordial follicle will convert to secondary follicle. Secondary follicle will convert to Graafian follicle. When the follicles are developing, when you see the structure of the follicle, right? So this is your ovum, right? So in addition to the ovum, there will be a fluid collection that is called antral fluid. You might heard that. When the follicles are developing, inside the developing follicle, there will be a fluid collection that is called antral fluid. This is called antral fluid. As the ovum develops, as there is a fluid collection into the ovum as an antral follicle, right? So in a normal ovary, having a fluid collection, it's not always pathological. That is going to be a physiological one. So whenever follicles are developing, you can have a cystic lesion here. The reason is when the follicle is developing, there will be a fluid collection. There will be a cyst. So if I do the scan to a woman, if I do a scan for a girl, that is not pathological. That is their developing follicle. That is their developing follicle. Right? So having a fluid collection or having a cyst in a woman, it's not always pathological. Sometimes it might be a physiological as well. Okay. So the cyst can be divided into two. One is physiological cyst. Second one is pathological cyst. The pathological cyst can be benign or malignant. Right? Pathological cyst can be benign or malignant. Are you all clear? So the cystic lesion in the ovary can be a physiological cyst. That is the first information you need to understand now. The cystic lesion in the ovary can be a physiological cyst or can be a pathological cyst. So if it is a pathological one, it could be a benign one or it could be a malignant one. Now you have a question. How to differentiate whether this is physiological cyst or pathological cyst? That is the first question. Second question you are having, how to differentiate whether this is benign or malignant. So when a patient presented to you with a cyst, these are the two questions you need to find the answer. What are those two questions? First, whether it's physiological cyst or pathological cyst. If it is pathological, then whether it's benign or malignant. Do you understand, Tushan? Right? Right? So these are the basic questions. So don't try to memorize anything. So you just work out on that topic. Right? Right? So first question is whether it's physiological. Second question, if it is pathological, whether it's benign or malignant. Right? Okay. So as I told you, so during the reproductive period, your primordial follicles are developing into Graafian follicle, and Graafian follicle will develop as a ovarian cyst, that is called functional cyst or physiological cyst due to antral fluid collection, right? So how do you know whether this is antral fluid or this is a pathological one? How can you differentiate? So there are features to differentiate the physiological cyst as well as the pathological cyst. Okay? So if it is a physiological cyst, always the cyst has only one component, single fluid collection. But if it is a pathological one, right, you might have multiple septae inside the cyst. So what I'm telling is, so if you see the cyst is divided into 2-3 rooms. Your fluid is collected into 2-3 rooms. This is called multilocular cyst. This is called multilocular cyst. But here you can see this is a unilocular cyst, only one room. So entire fluid is accumulated inside the cyst. Entire cyst is accumulated inside the cyst, right? So this is single room. This is multilocular. If you see the size of the cyst, right? So if it is a physiological one, right? Usually the cyst size will not exceed more than 3 centimeters. Will not be exceed more than 3 centimeters. So usually the functional cyst will be less than 3 centimeters. Right? Usually it will be less than 3 centimeters, 30 millimeter. So if it is more than 30 millimeter, it means it could be a pathological one. But pathological cyst can be benign. We are not always saying it's a malignant one, but it's not physiology. It's not physiology, but obviously it's pathology, but benign pathology. Benign pathology. So usually the antral fluid or antral cyst, your functional cyst is usually less than 3 centimeters. Unilocular, less than 3 centimeters cyst is, you can say, yeah, no, this is physiological one. This is actually developing follicle. After the ovulation, that follicle will disappear. Why? Once the Graafian follicle ruptured, then follicle will disappear. There is no follicles in the ovary. Do you understand what I'm telling? You will have a cyst during the follicular phase. Once the ovulation occurs, follicle will rupture and the cyst will disappear. This is your physiological cyst. So when you see the scan, when you look the ultrasound scan, right, the cyst might be less than 3 centimeters, unilocular, then you can say this is a physiological cyst. So will you worry if somebody have a physiological cyst? If somebody have less than 3 centimeters cyst in the ovary? Yes, Lasanda? Are you worrying if somebody has less than 3 centimeters cyst?
No, sir.
No, we are not worrying. Just tell the patient, no, this is the normal physiology. Each and every woman will have this cyst. The women who are having ovulation, definitely they will have this cyst. You don't need to worry, you can go home. So this is a very important information I can tell you, because even a lot of doctors, a lot of medical students asking me, so last week they have done the scan for me and they said there is a cyst, 3 centimeter cyst. What to do? What to do? Nothing. Wait, it will rupture. Once it ruptures, the ovum release, there won't be any cyst. When we are doing the repeat scan in 6 weeks time or 2 weeks time, 3 weeks time, there won't be any cyst. Why? The follicle will get ruptured. It will disappear, right? So this is your physiological cyst. So in premenopausal woman having ovarian cyst less than 3 centimeter, it's not significant. It's physiological. So when we are going to worry when a premenopausal woman having cyst is, it's if it is more than 3 centimeter. Okay. If a premenopausal woman presented with abdominal pain or something, right? So if the cyst size is more than 3 centimeter, that is significant. Okay. Until 3 centimeter, you don't need to worry. Right. So what about the postmenopausal lady? Is applicable, this 3 centimeter rule is applicable or not applicable? What do you think? Yes, what do you think?
So not applicable, right?
Why? What's the reason? Why 3 centimeter is not applicable? Anyone? Please try to understand.
Due to menopause, all follicles are depleted, sir.
Very good, very good. So due to menopause, there is no ovulation. So here in premenopausal woman, we told during the follicular development, you are having the Graafian follicle. That's why you can accept up to 3 centimeter cyst is physiological, right? So in postmenopausal ladies, there is no ovulation. There is no ovum development. Then how can you explain this central follicle? How can you explain this Graafian follicle? No, you can't. That's why in postmenopausal woman having cyst more than 1 centimeter, even significant. More than 1 centimeter, even significant. Do you understand what I'm telling? So this is the first. So actually, I was explaining these much of things to you to understand the basics. So I can tell simply with the one word. So almost I took 20 minutes to explain this 3 centimeter and 1 centimeter to make you to understand. Otherwise, I can tell in simple way. Premenopausal, more than 3 centimeter significant. Postmenopause, more than 1 centimeter significant. So you need to know why is it. So in postmenopausal, even it's more than 1 centimeter, that is significant. Right? But in premenopausal, up to 3 centimeter, you don't need to worry. You can say, no, this is physiological. This is just the follicular development. No need to do anything. You can just reassure, no, it's a normal physiology. You can go home. Right? Okay. Right? So first thing is, this is the first thing. So first we'll discuss about the postmenopausal woman, then we'll come to the premenopausal woman. Right? So the majority of the women in postmenopausal ladies might have cyst that is more than 1 centimeter. We take it as pathological. We take it as pathological. Right? Now, if a woman having ovarian cyst more than 1 centimeter in postmenopausal woman, right? So we have doubt. This is definitely pathological because it's more than 1 centimeter. It can't be a physiology. This is pathological. So we have a doubt. What is it? Whether it's benign or malignant. That is our question. Okay. So obviously in postmenopausal more than 1 centimeter, we know this is pathological. So this pathological cyst can be a benign cyst or might be a malignant cyst. So as a clinician, so our question is, whether it's benign or malignant. So how we are going to identify, or how we are going to diagnose whether it's benign cyst or malignant cyst? Okay, that is our first question. So most of the cyst in the postmenopausal, majority of the cyst in the postmenopause is going to be benign. Majority of the cyst is going to be benign, but still there is a high chance to have a malignancy as well. So obviously, as Sanjeevan told, so for the confirmation of malignancy, we need to have a histology, tissue biopsy. Confirmation of malignancy, we need to have a tissue biopsy. If you see the postmenopausal woman, around 5 to 17% of women will have cyst. So are we going to do the surgery for 5 to 17% of women in the world? No, it's not applicable. Is it possible to do surgery for 17% of the women, postmenopausal women in the world? No, it's not applicable. We can't do that. So then what we can do, we can identify the women who are having high risk to have malignancy. Right? Right. So in premenopausal woman having less than 3 centimeter but cystic and solid area, is it physiological? Just answer. Don't. Okay, we'll ask from the others. Kavinder, what do you think?
It can consider about its malignancy.
Oh, pathological. Yes, I told you. So cystic and solid or multilocular can't be a physiological one. So in Graafian follicle, it will be a unilocular, no follicle, no solid area. So unilocular, cystic mass less than 3 centimeter, always physiological. Right? So even though it's less than 3 centimeter, multilocular or maybe a solid area, then you have to consider it as a pathological. That is simple. Right, fine. So here, as this postmenopausal woman presented with more than 1 centimeter, we have a question whether it's benign or malignant. So we need to assess the risk of malignancy of the cyst. Right? Whether it's benign, whether it's malignant. So we need to assess the risk. What about the risk of malignancy, having malignancy? Because if the risk of malignancy is high, then you can take the biopsy. So you can manage according to the risk of malignancy. If the risk of malignancy is less, it's most likely to be a benign. So then you don't need to do the biopsy. You can manage conservatively. Do you understand? So this is your aim. So this is how we are managing the ovarian cyst. Right? This is how we are managing the ovarian cyst. You will get so many questions on this. Right? So you need to understand. Of course, it's a bit difficult, but try to understand. Right? So your aim, always you have to study with the concept. What I'm going to do it. So first, when a woman presented to you with the ovarian cyst, the first question, you need to find whether it's physiological or pathological. So how to differentiate whether it's physiological or pathological? Just check whether it's unilocular, multilocular. Is there any solid area? No. Then check the size. The size is less than 1 centimeter. You can say, no, this is physiological. You can go. No need to worry. If the size is more than 1 centimeter or solid area or multilocular cyst, then you can say, yeah, this could be a malignant. It's anyhow, it's pathological or could be malignant or benign. So your aim is to differentiate whether it's benign or malignant. So you need to assess the risk of having malignancy. Even though majority is benign, there is a chance. Right? So how to differentiate? How are you going to differentiate whether it's benign or malignant? Yes, anyone? How are you going to differentiate benign or malignant? No, don't straight away jump to investigations. This is the question always I'm telling to my students. So even if you see see my notes, I have put it in that order. History. There are some history. There are some features will help you to suspect whether it could be malignant or benign. There are some examination finding. It will help you to find out whether it's benign or malignant. There are some investigations that is under investigations. Your CA125 ultrasound scan and all are coming, right? So very simple. So just think about that. So then it's completely easy, right? So your aim is to find out whether it's benign or malignant. So this is how you are going to do the Viva class. When you come to the Viva class, so then the history. What are the things you are going to ask in the history? What are the examination features you are going to look? Then how are you going to investigate? Finally, how are you going to manage? Okay, this is how we are going to do it in the Viva. This is how you are going to manage the patient when you are becoming a clinician. Right, okay. So in history, what are the things we are going to ask? What are the features? So how they will present? How they will present? How they will present?
Dyspeptic
Yes.
symptoms.
Sorry?
Dyspeptic symptoms.
Right. So the presentation of ovarian cyst can be in, so mainly they set in three ways. One, so they might present with the cyst accident. Right. So you might heard the cyst accident. What is cyst accident? So that is a symptomatic cyst. So cyst can be a symptomatic cyst. Right. Second one is cyst can be present with the cyst accident features, or right, symptomatic cyst may be a symptom related to the cyst or symptom related to the cyst accident. Second one, most of the cysts are diagnosed during the other procedure, accidental finding. So while you are doing the ultrasound scan for ureteric colic, while you are doing the ultrasound scan for heavy menstrual bleeding, you found a cyst. While you are doing the ultrasound scan for appendicitis or some abdominal pain, you found a cyst. Accidental finding. That is asymptomatic. This second, symptomatic cyst. So symptom can be a acute symptom. So as Kavinda told, maybe a malignancy related symptoms. We'll come to the symptom a bit later. And third one, patient might present with disseminated features. Disseminated features. So if it is a malignancy, right? So that malignancy might spread to the liver, brain, spinal cord, right? So then patient might present with ascites, shortness of breath, hemoptysis, headache, severe back pain, right? Loss of appetite, loss of weight, disseminated features. See, very simple. So when a patient presented with suspicious of ovarian mass, these are the questions you need to ask, right? So they can present with the symptomatic cyst. Maybe symptom might be related to cyst or might be related to cyst accident. Second, they might present with accidental finding for non-gynecological or gynecological condition. So for example, when somebody undergoes scan for the uterine fibroid, there might be a cyst. That is second. Third one, they might present with disseminated features. Right, fine. Okay, we will come to the first one, symptomatic ovarian cyst. How they will present in the symptomatic cyst? One, so they might present with sudden onset of abdominal pain secondary to the cyst accident. So what you understand by cyst accident? Acute severe abdominal pain associated with nausea, vomiting. Sudden onset of acute severe abdominal pain associated with nausea, vomiting. Yes. So could be due to some accident. So already existing cyst. There is a cyst. So there might be accident in the cyst. So what are the conditions might be cyst accident? What are the? There are three conditions. Yes. Lesson cyst accident. There are three.
Twisting.
Twisted ovarian cyst. Yes. The ovary might twisted. Yes. Twisted ovarian cyst. That is called ovarian torsion. Yes. Second, the cyst might get ruptured. Once cyst rupture, then fluid will leak into the peritoneal cavity. That might irritate the peritoneum and patient might present with the pain. Right? So second one is ruptured ovarian cyst. And third one, there might be bleeding into the cyst, hemorrhage into the cyst. When the bleeding occur into the cyst, what will happen? The blood is going to accumulate inside the cyst. So then cyst wall will get distended and patient will have severe pain. Severe pain. Very good. You people are on track. You are answering very nicely. Right? So these are the three presentation of cyst accident. Ruptured cyst, ovarian torsion, hemorrhage into the cyst. So all kind of these cyst accident might present with sudden onset of abdominal pain. Sudden onset of abdominal pain. Okay, lesson there. May be associated with abdominal nausea and vomiting, right? So just you will get the SBA like this. 42-year-old lady presented with sudden onset of abdominal pain, nausea, vomiting for 2 hours duration. Or sometimes you might have a patient like this in Viva. Or sometimes you might have a patient when you are practicing maybe as a GP or maybe as a medical officer in the hospital, sudden onset of abdominal pain. So then you have to think this differential diagnosis. Could be a ruptured ectopic pregnancy. Could be a cyst accident, maybe rupture, torsion, hemorrhage. There is second differential diagnosis. Could be appendicitis. Yeah, could be. Right? Could be a ureteric colic. Yes, could be. Or maybe gastroenteritis, or maybe musculoskeletal pain. Those are the different. Sorry, the urinary tract infection also. Those are the differential diagnoses. So this is how we are working on that. So when a patient presented with abdominal pain, you are having a differential diagnosis. Then you ask some questions to differentiate each and every condition, and finally you are coming to the diagnosis and manage. Yeah, acute pancreatitis, yes, but the site might vary. So acute pancreatitis might be upper abdominal pain. Here, so our department is in the lower part. We don't go much to the upper part, right? Fine. So they might present with cyst accident feature. So sometimes this cyst might have some vague symptoms, right? So you can't, they don't have a specific symptom with ovarian cyst or ovarian malignancy, but they might have some kind of vague symptom like abdominal bloating, mild abdominal pain, right? Or maybe abdominal distension. So abdominal mass, dyspeptic symptoms, right? So this is sometime might be secondary to the ovarian cyst. So in history, we are asking some questions to find out the mass. So if it is a mass, so then you can differentiate the mass from benign to malignant. So if it is a benign mass, usually the increasement of size will be less, slow. But if it is a malignancy, the mass is increasing very fast. So then you can ask, so what is the duration of this mass? How about the progression? Right? So patient might say, I noticed this mass by 3 months back. Now it's almost like 30 weeks pregnant size. So then you have to think it can't be a benign one. So if it is benign one, within 3 months time, it won't enlarge like this. So then it's high likely to be a malignant. So along with the cyst, I'm having some kind of dyspeptic symptoms, shortness of breath, loss of appetite, loss of weight. So it's most likely to be a malignant site. Do you understand? So we are asking some question to find out whether is there any possibility to be a malignant, right? So then you can ask some risk factors for the malignancy. If somebody has risk factors for the malignancy, then so the ovarian cyst high likely to be a malignant site. So what are the risk factors for the ovarian malignancy? Family history, very good. So family history of what? What are the malignancies having familial tendency with the ovarian CA? What are the family history?
BRCA1 2.
Okay, BRCA1. So means how are we going to ask from the patient? Amma, do you have BRCA1 my family history? Will you ask like that? So then you need to ask. Yeah, of course, you are correct. As a medical practitioner, you need to know the BRCA1 or BRCA2. Yes. What else? colony. That's yes. So Lynch syndrome, HNPCC, Lynch syndrome. Right? Those are the things might associated with the malignancy. So what are the malignancy you are going to ask? What are the malignancy you are going to ask? With the family history of malignancy, do you have any
breast cancer, colon cancer,
breast CA, colon CA? Yes. What else? Stomach CA, endometrial CA, right? Prostatic CA. Yeah. Those are the malignancies mainly associated with the ovarian CA, or even the ovarian CA, family history of ovarian CA. Family history of ovarian CA. First, we are asking about the family history of ovarian CA. Right, so there are criteria to find out whether it's significant family history or not. So I have mentioned in my notes, you can go through that. Right, significant family history or non-significant family history. So you can ask about the family history. That is one risk factor. What are the other risk factors? Nulliparity. Right, nulliparity. If somebody doesn't have the baby, then risk of malignancy is high. Right, so if somebody ovulating a lot, several times they are ovulating, right, what will happen? Every time when they are ovulating, the so the epithelium will rupture, and again it's proliferate, rupture, proliferate, rupture, proliferate, rupture, proliferate. So repeated proliferation and rupture might be a risk factor for malignancy. So number of ovulation increase is a risk factor for ovarian CA. So what are the conditions will lead to increase ovulation?
Early menarche and late
early
menarche.
menarche.
Very good. Early menarche, late menopause. So these are the risk factors. Early menarche, late menopause, nulliparity. So if you deliver the babies, then you are giving 10 months off for your ovary. If you deliver 110 babies, 100 months you are giving off to the ovary. So then risk is markedly reduced. Do you understand? So early menarche, late menopause, nulliparity, family history. Right? These are. What about the OCP?
Protecting.
What about OCP?
Protecting.
Yes, OCP is protective because it prevents the ovulation. So whatever the medication which prevent the ovulation is protective. Because
It's protective. Being PCOS protective.
PCOS will not be a risk factor for a ovarian CA, because the problem with the PCOS, there is no ovulation. Right? Fine. So what about the smoking? Smoking is a risk factor, not a protective. It's a risk factor, right? So the smoking is protective for anti-estrogenic condition like endometrial CA, endometriosis. Those conditions, the smoking is protective. But in ovarian CA, it's not protective. Okay, right? So fine. So now you people have good knowledge on the history. What are the things we need to ask in a woman presented with ovarian CA? Then how to differentiate whether it's benign or malignant. So you can't confirm the benign and malignant with the history. You can find out some kind of idea or some kind of risky assessment in your history. Then yes, this could be a benign mass. This could be a malignant mass. So then what we are going to do, we are going to do the examination to find out the features of benign and malignant mass. Okay. So what are the things we are going to examine in the examination to differentiate the mass, right? So usually, if it is a benign mass, right, there is usually very smooth surface. Smooth surface. Usually firm in consistency. You can easily find the borders. Borders are very clear, right? And it's usually non-tender, right? So when you palpate, there won't be any hepatomegaly or splenomegaly, organomegaly. There is no free fluid, right? So this is, and when you check the mass will move, because the benign cyst will not form any adhesions with the adjacent tissues. If it is a malignant tissue, those malignant tissue will infiltrate into the adjacent tissues. So if it is ovarian malignancy, that will infiltrate into the bowel, that will infiltrate into the pouch of Douglas, that will infiltrate into the uterus. So then what will happen? The mass will adhere to the adjacent structures, then it will not move. So when you do the examination, there are some features will suggestive of malignancy, ill-defined margin. You can't find the margin because the malignant mass might have irregular margin, ill-defined margin, right? So irregular surface won't be smooth, but benign, you can see the surface is very smooth. It's irregular surface, hard in consistency, most likely to have the solid component. So the consistency is very hard, immobile, adhere to the adjacent tissues. When you check the organomegaly, there might be a hepatomegaly, there might be a splenomegaly, organomegaly, possibility of organomegaly, and also patient might have free fluid in the abdomen. What is free fluid? Ascitic fluid. The fluid is leaking into the abdominal cavity from the omentum as well as peritoneum. Ascitic fluid, free fluid. That is indicating the malignancy. Okay, right? So the examination features, few examination features will help you to identify the malignancy. So then with the history, with the examination, now we have some idea it could be a malignant or it could be a benign. It's most likely to be a benign. So when you come to the Viva class, then you have to say like that. So this patient doesn't have any history of ovarian malignancy, and this mass is slowly progressing over a period. On my examination, this is the right side mass, not a bilateral mass, and smooth surface, well-defined margin, right? Firm in consistency, freely mobile, not adhered. So no organomegaly, no free fluid. So my probable diagnosis, it could be a benign cyst. So you are suspecting it's a benign cyst. So I'm asking one MCQ. Freely mobile masses are highly likely to be a benign. True or false?
Sir.
Yes?
False.
That's true, right? If it is freely mobile mass, mean that is not adhered to the adjacent tissue. So it's high likely to be benign. Yeah. So if the mass is fixed or adhered to the adjacent tissue, then it could be a malignancy. Yeah, true. That is true. It could be a malignancy. But still, with your history and examination, obviously, you can't diagnose whether it's benign or malignant. So you need some more evidence to confirm it. So the definitive one is obviously you need to take the biopsy, but as the biopsy taking is an invasive procedure, before we cut the mother, we are assessing the possibility of having malignancy or risk of having malignancy. If the risk is very high, then only we are going for an invasive procedure. Is tender is a malignant features? Actually, with the tender, you can't say whether it's malignant or not, because some malignant masses are tender. Even a benign mass with torsion, they might have tenderness. So that's why we can't surely say whether it's benign or malignant, but features might suggestive of malignancy or not. Right? Okay, fine. So now, what are the investigation we are going to do it? What are the investigation we are going to do it? Right. The first investigation is ultrasound scan. So something you could feel it. There is doubt of ovarian mass, but we don't know. So it could be you might think it's ovarian mass, it could be a uterine mass. It could be a bowel mass. It could be a tubal mass. We don't know. We don't know the origin of the cyst. Right? So then what you have to do is first you have to do the ultrasound scan to check where this mass is originating. what is the origin of this mass, right? So the first investigation, you need to do the ultrasound scan. So in the ultrasound scan, you can have two kind of scan. One is transvaginal scan, second one is transabdominal scan, right? Transabdominal scan and transvaginal scan. Sometime in addition to the transvaginal and transabdomen, we may have to do the Doppler study as well to check the blood flow to the cyst. So in the ultrasound scan, we are checking three things. One, transabdominal scan. Second one is transvaginal scan. Third one is Doppler study of the cyst. Right, fine, good. So when are we doing the transvaginal scan? Why are we doing the transvaginal scan? Why are we doing the transabdominal scan? Why are we doing the Doppler study? Right. So the transvaginal scan will help you to identify the small cyst which is confined to the pelvis. Right? Because the transvaginal scan has good clarity. Clarity of the image is very good with the transvaginal scan. But there is a problem with the transvaginal scan, the penetration of the ultrasound wave. Penetration of the ultrasound wave. So if you put the transvaginal scan probe here, that ultrasound wave might penetrate up to the adnexia. But if you have a cyst up to right hypochondrium, very big cyst, if you do the transvaginal scan, this scan probe will not detect the upper part of the cyst because the penetration of ultrasound scan wave is less. So if you want to assess the endometrium, if you want to assess the small ovarian cyst and the nature, then you can do the transvaginal scan. But if the mass is large, or if you want to assess the secondary deposit into the liver, spleen, peritoneum, omentum, then you may have to do the transabdominal scan. That's what I told. You need to do the transvaginal as well as the transabdominal scan. So especially for the postmenopausal ladies, when they are presenting with some kind of out symptoms, you can offer the transvaginal scan because there might be a small cyst, 3 centimeter, 2 centimeter, even 2 centimeter. It's significant for the postmenopausal lady. But with the transabdominal scan, you might miss that 2 centimeter cyst because the clarity of the image of transabdominal scan might be less. So you can offer the transvaginal scan for a postmenopausal woman to check the cyst. If the cyst is too large, to assess the characteristic of the cyst and to assess the extent of the malignancy, you may have to do the transabdominal scan. So when you do the scan, what are the things we are going to look for? Because few features suggestive of malignancy, few features suggestive of benign. So we are looking for the features suggestive of malignancy as well as benign. Right? So what are the features we are looking? So in the cyst, you can check the thickness of the capsule. Usually benign, the capsule thickness is thin. If it is a malignant, very thick capsule. And you can check the regularity of the capsule, whether it's regular or irregular. You can check any solid component into the cyst. So capsular thickness, regularity, solid component, and septae, any septae inside the cyst, whether it's unilocular cyst or bilocular cyst or multilocular cyst. Right? And you can check the echogenicity, whether it's homogeneous or heterogeneous. What do you think about homogeneous or heterogeneous? So if you have a papillary projection or solid area, so then your echogenicity, the echogenicity will be mixed. Some are solid, some are fluid, so then mixed echogenic pattern, heterogenic pattern. But if everything is solid, so cystic, then it's homogeneous. Then you can check the solid component. You can check the septae. You can check the papillary projection. You can check the thickness of the cyst wall. You can check the regularity of the cyst, and you can check whether it's bilateral or unilateral, because the bilaterality is a feature of malignancy, right? So if somebody has a bilateral cyst, it's high likely to be a malignant. Bilaterality is a feature of malignancy. So whether it's bilateral or unilateral, then you can look for any features of secondaries, any secondary deposit in the liver, any secondary features in the spleen. You can check any features or secondaries in the liver, and you can check for the free fluid into the abdominal cavity, ascitic fluid. Those are the ultrasonic features might suggestive of malignancy. And if it is a malignancy, one of the feature of malignancy is, right? One of the feature of malignancy is, you might heard angiogenesis. What you understand by angiogenesis?
Increase vascularity.
Yes, new vessel formation. So in malignancy, there will be more and more new vessels formation. So when compared to benign cyst, the malignant cyst will have highly vascularity. The benign cyst will not have that much of vascularity. So if you do the Doppler study to the cyst, what will happen to the vascularity will be high. See how simple this one. So each and every step, the aim of management is to differentiate whether it's benign or malignant. So very simple. So don't complicate it. So when a patient presented to you, the first at the beginning, what you have done is you have checked whether it's physiological cyst or pathological cyst. Once you think it's a pathological one, so now you are taking the history, you are doing the examination, you are doing some investigation to differentiate whether it's benign or malignant. That is the summary, nothing else. So for that, you need to know what are the history suggestive of benign, what are the history suggestive of malignant. What are the examination findings suggestive of benign, what are the examination findings suggestive of malignant. What are the investigation or especially ultrasound features suggestive of benign? What are the ultrasound features suggestive of malignant? That's it. Right. So then we can do some blood test to assess the malignancy and benign. That is called tumor markers. That is called tumor markers. Have you heard the tumor markers? Of course, you might know because you are studying those things in surgery and all. Right. So the tumor markers mean, so different cells, as I told you at beginning, in the ovary you are having different type of cells. These different type of cells can secrete different chemical mediators. Say for example, if you see this epithelial cell of the ovary, this epithelial cell has ability to secrete a chemical mediator called carcinogenic antigen 125. So if you have cell proliferation, excessive cell proliferation in the epithelial cell of the ovary, what will happen? Those cells are going to produce CA125 in higher level. So when you do the CA125, if the CA125 is high, then what you can say? What you can say? What you can say? So
Proliferating more, right?
very good. So this mass is originating from the epithelium of the ovary. That is the first thing you can say. Your epithelium of the ovary is highly proliferating. So that is your tumor marker. So we are doing some tumor marker. The commonest tumor marker which we are doing is CA125, because the CA125 is secreted by the epithelium of the ovary. In epithelial ovarian tumor, it could be a benign or malignant, but in benign cells, the CA125 proliferation will not be very high. But if it is a malignant lesion, the CA125 proliferation, it's going to be very high. It's going to be very high. So if you do the CA125 level for the epithelial cells, if it is high, then you can say it could be a epithelial mass, and also it's high likely to be a malignancy. Do you understand what I'm telling? Right? So elevated CA125 level could be a epithelial mass, and it's high likely to be a malignancy. But you can't say 100% this is malignancy, because not only the epithelial cell, also some other cells also can produce the CA125 level. Produce this CA125. What are the cells? Your peritoneal cells. So peritonitis, simple peritonitis, fibroid, endometrioma, that is also ovarian mass, epithelial mass, which can increase the secretion of CA125. So the CA125 is not a 100% sensitive method to diagnose the malignancy, but you can suspect. You can suspect. When the CA125 level is high, you can suspect it could be a malignancy. And second information you need to know about the CA125 is, this CA125 is secreted by the epithelial cells. So if the tissue proliferation is from the stromal cell, or if cells are proliferating, if you have a tumor in the germ cells, will you have elevated CA125 level? No. Your CA125 level might be normal, because the excessive proliferation is from the germ cells. Excessive proliferation from the stromal cells. So the CA125 only elevated in epithelial cell proliferation. Okay. So when you talk about the epithelial cell tumors or epithelial cell malignancies are very common in postmenopausal ladies. Right? Epithelial cell malignancies are very common in postmenopausal ladies. So if a postmenopausal lady presented with ovarian mass, the first tumor marker we need to do is CA125, because that is the commonest mass. That is the commonest mass. But if it is a premenopausal ladies, 30-year-old lady, then the chances to have the epithelial cell is less. You can't say no. There might be epithelial cell tumor, but chance is less. But in addition to the epithelial mass, they are reproductive women. They might have germ cells. They might have highly active stromal cells, like your granulosa cell, theca cells, right? Fibrous tissue. So you can have malignancies from the germ cells. But in postmenopausal ladies, the follicular count has been dropped. Less follicles. So the mass originating from the follicles might be less. Do you understand what I'm telling? So if it is a postmenopausal ladies, always first investigation we need to do is CA125. If it is a premenopausal lady, of course we need to do the CA125, but CA125 is not enough. You need to do some other tumor markers to the premenopausal ladies, because the germ cells might produce different tumor marker. The granulosa cell will produce different tumor marker. Teratoma will produce alpha-fetoprotein, different tumor marker. Right? So LDH will be high in this germinoma, different tumor marker. So especially in that is the difference only between this premenopause and postmenopause. If a postmenopause woman present with the ovarian cyst, then first investigation or first tumor marker we are doing is CA1 to 5. We can diagnose most of the malignancies with this CA1 to 5. But if it is a premenopausal lady, along with the CA1 to 5, you need to do some other investigation like LDH, beta HCG, choriocarcinoma, alpha fetoprotein, teratoma, or estradiol level could be a granulosa cell tumor. Inhibin B could be a granulosa cell tumor. So we are doing CA 19.9. So there are so many other tumor markers we are doing, right? So this is the take-home message you need to understand. If it is a postmenopausal lady, first we'll do the CA1 to 5. We don't routinely do the rest of the tumor markers. First you check the CA1 to 5. CA1 to 5 level is less, but still other features suggestive of malignancy. Then only you have to do the rest of the tumor markers. But if it is a premenopausal lady, CA1 to 5 alone, it's not enough. You need to do the other tumor markers to find out the other type of malignancy or other type of tumors as well. Right? So now we have discussed about the ultrasound features. We have discussed about the second investigation, your tumor markers. And third one, will you do the other screening method routinely, like radiological method like CT, MRI? Will you do the CT, MRI? Will you do the CT and MRI? No. CT and MRI, we don't do routinely. When we are doing the CT and MRI, if we are suspecting the malignancy, once you assess the risk of malignancy, if the malignant risk is high, then you need to assess the spread of malignancy from the ovary. Is it spread to the omentum? Is it spread to the liver? Is it spread to the uterus? Is it spread to the bowel surface? Is it spread to the spleen? Is it spread to the lymph node? To assess the spread of malignancy, you may have to do the CT and MRI. So the CT, MRI are not routinely recommended for ovarian cyst. So these are MCQ points. These are MCQ points. Okay, these are MCQ points. So routinely, so MRI is routinely recommended for a woman with cyst of 8 centimeter. True or false? If it is 15 centimeter, large cyst, still false. Whether it's 15 or 20, doesn't matter. You have to do rest of the things to assess the malignant risk. If it is a malignancy, yes. If you are suspecting malignancy, yes. Do you understand? It's not routinely recommended. Right, okay. Now, with this investigation, how are you going to calculate the risk of malignancy? So with this investigation, how are you going to calculate the risk of malignancy? There are several formulas we are using to calculate the risk of malignancy, right? So the most common way to assess the risk of malignancy, you might heard, that is called risk malignant index, RMI, right? Risk malignant index. That is the most common way to assess the malignancy. More than this RMI, there are other methods to assess the risk of malignancy. One is, the second one is most common is IOTA, International Ovarian Tumor Association. IOTA, right? So the RMI is most common. Second one is IOTA, then OVA, ROMA. So you don't need to know what is OVA, how to calculate by the OVA. You don't need to know what is Roma, how to calculate the Roma. You don't need to know that. Okay, so you need to know what is RMI, what is IOTA, right? So the RMI, what is RMI? So the RMI calculation by three components. What are those three components? Is menopausal status. Second one is ultrasonic features. Third one is CA125 level. Menopausal status, ultrasonic features, CA125. So with these three features, right, we are calculating the RMI, right? How RMI is menopausal state into ultrasonic features into CA125 level. So you multiply all these three. This is the RMI. So the menopausal system, we have the scoring way. If it is a pre-menopause, right? If it is a pre-menopausal lady, the score is 1. If it is a post-menopausal lady, right? Post-menopausal lady, score is 3. This is how we are giving the scoring system for the menopausal state. Pre-menopausal lady, score is 1. Post-menopausal lady, score is 3. Right? That is 1. Second thing, ultrasonic features. There are 5 features in the ultrasonic features. What are those 5 features, Kavind?
Bilateral, free fluid,
Bilateral, yes. Bilateral,
free fluid,
solid
free fluid,
area,
sir.
bilateral, solid area,
Solid.
multilocular, free fluid, and features of secondary metastasis, liver mets or spleen mets. There are 5 features. Bilateral cyst, having solid area, having multilocular cyst, free fluid, and secondary features. So there are 5 ultrasonic features. Among these 5 ultrasonic features, if you don't have any of these features, your score is 0. If you have one feature, your score is 1. If you have 2 or more, then your score is 3. 2 or more, the score is 3. So menopausal state, pre-menopause 1, post-menopause 3. Ultrasound, there are 5 features we are looking. One is bilateral, solid area, multilocular, free fluid, features of secondary. Out of these 5 features, if you don't have any features, score is 0. If you have one feature, score is 1. If you have 2 or more, score is 3. Then you can do the CA125. Once you know the value of CA125, then you can calculate the risk malignant index. So I'm telling a scenario, just calculate the RMI and let me know. 50 years of postmenopausal lady found to have unilocular homogeneous 20 centimeter ovarian cyst. The CA125 level is 45. No free fluid, no features of secondary. What is the RMI score? I'm repeating, 50-year-old postmenopausal lady found to have unilocular homogeneous right side right sided ovarian cyst without free fluid, without secondary features. CA 1 to 5 level is 45. What is the RMI? Okay, menopausal state, she is post-menopause. What is the score? 3. What is the CA 1 to 5 level? 45. Right? What about the ultrasonic features? Of course, it's 15 centimeter large cyst, but this is unilocular, not multilocular. Unilateral. So there is no bilateral features, no solid component, homogeneous, no free fluid, no features of secondary. So how many ultrasonic features are there? 0.
Zero. No any ultrasound.
What is the score? 0. 0
Zero,
into 3 into 45, it's going to be 0. So if somebody do mistake on this, then we need to send them to the scholarship class, isn't it? So the score is going to be 0. So it means the risk of having malignancy is going to be less. I'm telling another scenario. 65-year-old postmenopausal lady presented with abdominal pain, found to have bilateral 3 centimeter multilocular cyst. Right? And CA 1 to 5 level is 100. What is the RMI?
900.
900.
Simple, right? 900. Because her 65 years postmenopausal lady score is 3. Bilateral cyst, multilocular cyst. How many features? 2. So if it is 2 features, score is 3. CA 1 to 5 level is 100. So the RMI is going to be 900. Very good. So the RMI is going to be 900. Right? So the RMI is going to be 900. So now this is how we are calculating the RMI. Once you calculate the RMI, how to predict whether it's malignant or not? So how to predict is, if when you calculate the RMI, if the RMI is less than 25, the RMI value less than 25, the risk of having malignancy is less than 5%. Very less. So if the RMI is less than 25%, 25, the value is less than 25, the risk of having malignancy is less than 5%. So what you can do, you can manage conservatively. We will discuss how to manage conservatively. If the RMI value is 25 to 200, it's a moderate risk. RMI value is 25 to 200, the risk of malignancy is moderate. It's around 20%. If the RMI value is more than 200, the risk of having malignancy, it's going to be very high. That is 70%, more than 70%. Right? So more than 70%. So the postmenopausal lady cyst is managed depend on the RMI value. So if RMI value is less than 25, the risk of having malignancy is less, right? Risk of having malignancy is less than 5%. You can manage conservatively. How we are going to manage conservatively? You can repeat the scan in 6 months' time. You can repeat the scan in 6 months' time and repeat the CA 1 to 5 and calculate the RMI again, whether it's progressing or not. But in between, if the patient has symptoms like cyst accident, abdominal pain, obstruction features, then symptomatic cyst should be managed. asymptomatic cyst with RMI less than 25, you can manage conservatively with repeat scan and the repeat CA125 level. Are you all clear? Right. This is how we are managing the low risk malignant mass. If the RMI is in between 25 to 200, the risk of malignancy is moderate. It's around 20%, right? Risk of malignancy is moderate. It's around 20%. So if it is a 20% risk is there, then you need to manage, because this is postmenopausal lady, no, so we are not going to take the risk, then you have to manage it. So what are we going to do is, we are going to remove the ovary, not the cyst, because she's postmenopause, no point in keeping the ovary. So then you can remove the oophorectomy rather than doing the cystectomy. The oophorectomy by laparoscopy, you don't need to cut the mother even. You can do the laparoscopy and oophorectomy. But when you do the laparoscopy, you should be very careful. You should not rupture the cyst. Why is that? Sometimes there is a 20% chance of malignancy. So sometimes if it is a malignancy, once you rupture the cyst, then what will happen? That malignant tissues will spill into the peritoneal cavity and you are upgrading the malignancy. You are spreading the malignancy. That's why you should not allow the spillage of fluid into the abdominal cavity. So then how can you prevent it? You just put the bag inside the tummy through the umbilical port, right? And after removal of cyst, you just put the cyst into the bag, and then only you can rupture the cyst and take it off with the bag. So then you can avoid the spillage. So you can do the oophorectomy with the bag. So somebody asked, are we doing the BSO or affected ovary? Definitely BSO. Because if it is malignancy, there is a high chance of bilateral. And if she is postmenopause, we don't want to keep the ovary, so then we are offering the oophorectomy if it is a moderate risk child. If it is a high risk, more than 200, 70% of malignant risk. So if it is a high risk, what are we going to do? We are going to do the MDT meeting. What is MDT meeting? Multidisciplinary team meeting with the involvement of subspecialties like gyne-oncologist, oncologist, radiologist, right? So gynecologist, palliative care, pathologist, everyone will sit together and we'll have a meeting. Before the meeting, what we have to do is, we have to do the CT and MRI to assess the extent of disease. With the extent of disease, right, we can decide what we are going to do. Usually, so if the RMI is more than 200, it's high likely to be malignancy. So that patient should be managed by the gynecological oncologist. Gyne-onco surgeon, gynecological oncology surgeon will do the surgery. What is the surgery? Laparotomy, staging laparotomy. So the staging laparotomy including few steps. What are the steps? I have kept blank, so you need to write. So midline laparotomy, inspection of your peritoneum, thorough inspection of your peritoneum and the abdominal cavity and pelvic cavity, total abdominal hysterectomy plus bilateral sulfincho oophorectomy. You need to take the peritoneal fluid for the cytology. If no free fluid, then you have to do the peritoneal washing. Put the saline, wash the peritoneum and take it for the cytology. You have to do the omental biopsy or omentectomy, partial omentectomy. In addition to that, you examine the peritoneum as well as the lymph node. If you can feel any lymph node or secondary metastasis, you need to remove and take a biopsy. Those are the things we will do in staging laparotomy.
So, excuse me, sir, what about adjuvant chemo?
Right. That is depend on the staging of the malignancy. Today we are not going to discuss about the ovarian CA management. So if malignancy is very extensive, if we can't do surgery, then we give the chemotherapy, shrink the malignancy, then we can do the surgery later. That is adjuvant chemotherapy. Sorry, neoadjuvant chemotherapy. Right. So after surgery, if you have secondaries, then you can do the adjuvant chemotherapy. That is a ovarian malignancy. We are not going to discuss that part today. Today, I'm going to discuss how to manage this one. So that's depend on the RMI value. If it is less than 25, manage conservatively. Moderate, you do laparoscopic bilateral salpingo-oophorectomy. If it is severe, that one should be managed with the help of MDT. The surgery should be done by the gyne-oncologist. Yes, I'll tell the repeat staging. Gyne-oncologist, and that is going to be a staging laparotomy. Staging laparotomy, the midline incision, thorough inspection and palpation of the peritoneum, abdominal cavity and pelvic cavity, undersurface of the diaphragm. Cytology from the free fluid to peritoneal washing. Right? Total abdominal hysterectomy plus bilateral salpingo-oophorectomy. Removal of uterus, removal of bilateral ovary, removal of bilateral tubes. That is called total abdominal hysterectomy. We are removing the uterus. Bilateral salpingo tube, oophorectomy, ovary, tubes and ovary removal. Then we have to remove the omentum, that is called omentectomy. Palpate in the peritoneal cavity. If you can feel any secondary deposit in the bowel, maybe in the peritoneum, maybe in the lymph node, then remove it. That is removal of secondaries. That is your staging laparotomy. Okay. This is how we are managing the postmenopausal lady. Here, as it is a postmenopausal lady, as we know, the CA1 to 5 level will be very high because of postmenopausal lady, they are having high chance to have the epithelial cell tumor. So then you can do the RMI. The RMI will be very high sensitive method to assess the risk of malignancy in postmenopausal lady. Right? Now we come to the premenopausal lady. If it is a premenopausal lady, if it is more than 3 centimeter, it's risk, it's pathological. Then your features and everything is same as postmenopausal ladies, history, examination, investigation. So here the risk of assessing the malignancy, can you go with the RMI always with the premenopausal lady? What do you think? Is it okay to go with the RMI for premenopausal lady? No, we can't. The reason is the epithelial cell tumor risk is not much high in premenopausal lady. They can have malignant transformation, they can have tumors in the germ cells like teratoma, dysgerminoma, or they might have like a granulosa cell tumor, stromal cell tumors. They can have fibroma in the connective tissue. So they might have different other tumors as well. So in case of other tumors, right, your CA1 to 5 is going to be very low. So dysgerminoma might be a malignancy, it's a malignancy, but in dysgerminoma, your CA1 to 5 is going to be 2, 3. So if you calculate the RMI for a woman with dysgerminoma, what will happen? Their RMI is going to be low, then you can think it's a benign one and you are conservatively managing, but still patient is having malignancy. That's why for premenopausal ladies, you can't use this RMI. We are calculating the RMI. If RMI is high, then of course you can say it's a malignancy. If RMI is low, then you can't say this is not malignancy. Still, it could be a malignancy. That's why we are using another method to assess the risk of malignancy in premenopausal lady. What is that? That is your iota score. Right? That is your IOTA score. So the IOTA score will help you to assess the risk of malignancy, especially in young women. So this IOTA score, it's not basically depend on the CA125. That is basically depend on the ultrasound features. That is basically depend on the ultrasound features. So in IOTA score, you can see there are two rules. One is B rule, another one is M rule. There are features that suggestive of benign, that is your B rules. There are features that is suggestive of malignant, that is M rule. Right? Okay. So what are the B rules? What are the features suggestive of benign? One, unilocular cyst. If it is a unilocular cyst, then you can say it's high likely to be a benign. Second one, sometime inside the cyst, you can have a small projections. That is called papillary projections. So that solid component, this is called papillary or something solid projection. This solid component should be less than 7 millimeter. If it is more than 7 millimeter, that is high likely to be a malignant. So even though you are having solid component, that solid component is less than 7 millimeter, the risk of malignancy is less. So unilocular. Second one is solid component less than 7 millimeter. Third one, it could be a multilocular cyst. If it is a unilocular, then you can say it's benign, but it could be a multilocular cyst. Even though it's multilocular cyst, if the cyst size is less than 10 centimeter, then it's most likely to be a benign. That is the third feature. Multilocular cyst with less than 10 centimeter in size. That is benign. If multilocular cyst more than 10 centimeter, that is malignant. Got it? Multilocular cyst more than 10 centimeter is malignant. So now I have told you three features. One is unilocular. It could be a multilocular. If it is multilocular, it should be less than 10 centimeter. Third one is you can have solid component, but solid component should be less than 7 millimeter. And if you do the ultrasound scan, there should not be any blood flow, increased blood flow into the mass. If you have increased vascularity, that is suggestive of malignancy. So the blood flow should not increase. No blood flow on color Doppler. That is fourth one. Fifth one, acoustic shadowing. Actually, you don't need to know how the acoustic shadowing will be. That is an ultrasonic feature. So for the MCQ purpose, if you know presence of acoustic shadowing, that's enough. So there are 5 features which suggestive of benign. One is unilocular. Second one is multilocular, less than 10 centimeter. Third one is solid component less than 7 millimeter. Fourth one is no vascular flow on Doppler. Fifth one is aqueous shadowing on ultrasound features. Those are benign features. There are malignant features. What are the malignant features? One, irregular solid tumor, more than 7 millimeter, irregular solid tumor. That is one. Multilocular cyst more than 10 centimeter. That is 2. Ascites. That is 3. Sometimes you can have this small projection, even less than 7 millimeter projection. But even though it's less than 7 millimeter, if you have more than 4 small projection, more than 4 papillary projection, that is a feature suggestive of malignancy. And fifth one, predominant blood flow on Doppler. So there are 5 features of malignancy. Solid mass, multilocular more than 10 centimeter, papillary projection more than 4, ascites, increased vascularity. Those are 5 malignant features. Among these malignant features, if you have any one of these M feature, then you have to manage as malignancy. Any one of these malignant features, then you have to manage as malignancy. So we discussed now if it is malignancy, how we are managing MDT, CT, MRI, and you are staging laparotomy. So if you have M rule, any one of M rule, you manage as a malignancy. If you are suspecting as a benign, how we are going to manage? Now we know how to manage for the malignancy. So if we are suspecting as a benign, how we are going to manage? The benign management depends on the size of the cyst. Benign management depends on the size of the cyst. So first of all, you need to check whether it's physiological or pathological. If it is more than 3 centimeter, obviously it's pathological. If it is less than 3 centimeter, it's physiological. You can reassure and send. If a woman has, irrespective of size, maybe 4 centimeter, 5 centimeter, 6 centimeter, 8 centimeter, 10 centimeter, 12 centimeter, 20 centimeter, doesn't matter. Irrespective of size, if patient is symptomatic, you need to do the intervention. Okay. So if the patient is symptomatic, you need to do the intervention. If the patient is asymptomatic, your management will depend on the size of the mass. So you have excluded the malignancy with your risk malignant index as well as the iota rule. Patient is asymptomatic, then your management will depend on the size. So if the size is in between 3 to 5 centimeter, the size is in between 3 to 5 centimeter, asymptomatic, most likely to be malignant, benign, so then you don't need to do anything. That cyst will be ruptured in 2-3 months. That is a functional cyst, enlarged functional cyst. If it is 3 to 5 centimeter, no need to do anything. You can discharge the patient from the follow-up and reassure the patient. Nothing will happen. You can go home. If the cyst is 5 to 7 centimeter, right? Still, you don't need to do any intervention. If the patient is asymptomatic, still you don't need to do any intervention, but you need to do the follow-up. You have to do the repeat scan in 1 year time. Do the repeat scan in 1 year time. If it is 5 to 7 centimeter. If the patient has more than 7 centimeter, you can't leave this cyst, even though your risk of malignancy or even though your iota is less chance to have malignancy, doesn't matter. You need to take a biopsy to exclude the malignancy if the cyst size is more than 7 centimeter. So if it is more than 7 centimeter, you have to do the intervention. But obviously we know it's less likely to be malignant, but still we need to do the intervention. What kind of intervention we are going to do? We have to do the surgery. Okay. So in surgery, for the premenopausal woman, what kind of surgery you are going to do? Will you do the cyst only or will you remove the ovary? What are you going to do? Lasanda?
Cyst only.
Cyst only. Because she is mensurating. She is reproductive woman. Her ovary is functioning. So with the functioning ovary, is it okay to remove the ovary? No. So then you have to do the removal of cyst. So then how do you call that? That is called cystectomy.
Cystectomy.
That is called cystectomy. So you have to do the cystectomy. You have to do the cystectomy. Right. So what kind of surgery? Laparotomy or laparoscopy?
Laparoscopy.
Laparoscopy. Always laparoscopy, because laparoscopy has a lot of advantage. Less pain, less morbidity, cost effective, right? Less hospital stay, right? So the pain is less, bleeding is less, right? So you can do the laparoscopy. So if it is more than 7 centimeter, you can go for a laparoscopic cystectomy. So yeah, somebody asked if the size is very large, 25 centimeter, will you do laparoscopy? Obviously, that is contraindicated for the laparoscopy. Then how can you do the laparoscopy? If laparoscopy is contraindicated, then we can't do. If it is 25 centimeter up to this level, then you can't put the laparoscopy. Then you have to go for a laparotomy. So if you can do laparoscopy, better to go for a laparoscopy. If it is contraindicated too large, then you may have to go for laparotomy. Right? Say, for example, one woman, the ovarian cyst is 8 centimeter, CA 1 to 5 normal, iota OLA B rule, right? But still cyst size is 8 centimeter. Will you operate? Will you do the cystectomy? Yes, that's what I told. Even if it is benign, more than 7 centimeter, we need to do the cystectomy. There is no question on that. We need to do the cystectomy. But the patient say, no, I don't want surgery. Please, doctor, don't do surgery. What are we going to do? Because as I told you, even though the risk of malignancy and the iota score is less, there might be a small chance of having malignancy if the cyst size is more than 7 centimeter. That's why we are doing the cystectomy if it is more than 7 centimeter. So by 8 centimeter, patients say, no, I won't give the consent for the surgery. What are we going to do? No surgery without consent. Yes. Cyst aspiration with ultrasounds guided. So this is the answer I was expecting from you, right? And you answered. Cyst aspiration is not recommended at all for ovarian cyst. If you aspirate the cyst wall is inside, then what will happen? Again, the fluid will accumulate inside. Then again, it's reappear. So the recurrent risk is very high. That's why the cyst aspiration is not recommended anymore in post-menopause or pre-menopause. You are not doing the cyst. So if the patient not happy to do the surgery, then what is your next step? There might be some chance to have the malignancy. Then you need to assess whether she's having malignancy or not. So then what is the next step? Yeah, Disha?
We can assess the malignancy as you said.
No, we assess everything. It is normal, but it's 8 centimeter, but patient not happy to go for a surgery. What are we going to do?
Yeah, we can highly recommend the surgery to her. But if she is not willing, then we can repeat the scan in 6 months.
No, you need to do the MRI. If the patient refuses to go for a surgery, then we have to offer the MRI, because your MRI will assess the soft tissue very sensitive manner. So then you can see any malignant changes in the ovarian tissues. So otherwise, we don't do routinely recommend the MRI, right? That's how we study it. Even though if the RMI is less, so if it is no M rule, we don't do MRI. But if the cyst is more than 8, if the patient not willing for surgery, you have to offer the MRI to assess the cyst. So if the patient gave the consent for surgery, then you can do the surgery. That should be a laparoscopic cystectomy. If the cyst is very large, then you can go for laparotomy and cystectomy. Right? This is how we are managing the premenopausal woman. So the same thing as postmenopause, we are just assessing the malignancy index with the RMI as well as the iota score. If RMI is more than 200 or iota score has any malignant role, you need to arrange the MDT, CT, MRI for the assessment of extent of the disease and manage as a malignancy. If RMI is normal, your iota score is highly suggestive of benign mass, then your management will be depend on the symptomatic status as well as the size of the cyst. If the patient is asymptomatic, you don't need to be hurried to do any intervention, but the intervention will be depend on the size. If asymptomatic patient with 3 to 5 centimeter cyst, even you don't need to review them, that will be disappeared. So you can discharge them from the follow-up. If it is 5 to 7 centimeter, then you need to review them in 1 year time for the ultrasound scan again. If it is more than 7 centimeter, the surgery is recommended. The recommended surgery is cystectomy, preferably by laparoscopy. If cyst is large, you have to do the laparotomy. If the patient refuses to do the surgery, or if surgery is not possible at that time, to assess further, you need to do the MRI. Is there any size limit to tell laparotomy have to do? It's like that. If the cyst size is up to the umbilical region, then you can't go for a laparoscopy. The reason is we are putting the TOCA, that laparoscopic probe, right? So this is the mother's tummy. This is the umbilicus. What we do is we are putting the TOCA through the umbilicus, through here. So if you have a mass up to the umbilicus like this, so if you have a mass like this up to the umbilicus, when you put the TOCA will damage the ovarian cyst. So then it's not possible to do the surgery. So then you may have to go for a laparoscopy, laparotomy. But if the cyst is somewhere here, then you can put the TOCA and do laparoscopy. Sometimes if it is a single cyst, we do some adjustment. I think you don't need to know. So we can go through the Palmer's point and aspirate the cyst and do surgery. That is a bit difficult for you. It's okay, just leave it. So at least you need to know if the cyst is up to the 20-week size, then the laparoscopy will be difficult. You have to go for a laparotomy. But if the cyst is smaller, preferably you have to go for a laparoscopy. In premenopausal women around 40 years with abdominal pain, ultrasound scan suggestive of benign and cyst size is 4 centimeter. Will we do the cystectomy? That's not the cystectomy. Even the 4 centimeter cyst can be present with cyst accident. That is our worries. So even if it is a 4 centimeter, if the patient presented with cyst accident like torsion or ruptured ovarian cyst or maybe a hemorrhage, then we may have to think about the intervention. Irrespective of size, that's why I told you. So if the patient is symptomatic, we don't think about the size, we may have to do intervention. So if it is an ovarian torsion with 4 centimeter, will you leave the ovary? No. Not the ovary cyst? No, we need to do the intervention. Right? 8 centimeter cyst, patient refused surgery, did the MRI, found malignant features, but still patient is not willing. Next next is the medical treatment. Then what we can do, if the patient, even after malignancy, if the patient is not willing, then we can't do the medical treatment as well, because there is a ethic. Without the tissue confirmation, you can't give the chemotherapy, right? Without the tissue diagnosis, you can't do the chemotherapy. The reason is these chemotherapeutic agents are very, very side effect and very toxic, cytotoxic drugs. So without the tissue confirmation, you can't give the chemotherapy. So if the patient refuses to do the surgery, then let the patient to die. That's the patient's right to die, right? So I can tell you one example. So when I was registered, I was doing Magaragam appointment, right? So one lady, 27-year-old, one of the doctor's sister, presented with complex solid abdominal bilateral mass. Complex solid abdominal bilateral mass. CA125 level is 1500. Right? CA125 level is 1500. So the RMI is definitely more than 4500. So what is your diagnosis? Yes, what is your diagnosis? What is your diagnosis? It's malignancy. It's 4500 RMI, CA125 1500, bilateral solid ovarian CA. So then the MDT meeting has arranged, and according to the MDT meeting, they have decided to go for a staging laparotomy with TH, VSO, omentectomy and all. So they have opened up. So once we open up, there were a lot of infiltration and ovarian tissues are solidic region, and it's macroscopically it's looked malignancy. So then what they have done, they have removed the uterus, hysterectomy, bilateral salpingo-oophorectomy, right? Omentectomy, peritoneal washing, everything done. After 6 weeks, histopathology report came as bilateral TB oophorytis. Do you understand? So bilateral TB oophorytis. These are different presentations. So here, yeah, now what are we going to do? So do you want to remove the uterus, ovary, everything for an unmarried 26-year-old lady? She's a doctor's sister even, for a TB oophorytis. So why I am telling is, you can have a deviation of your presentation. You can have a misdiagnosis. So without the tissue confirmation, how can you give a chemotherapy? If it is a TB oophorytis, if you give chemotherapy, the condition will get worse. So you need to take a biopsy. Do you understand? Listen, all the time we can't say medical negligence, because there are possibility we can have the different presentation as well, right? So we can prove ourselves, because so according to the evidence, this is how the presentation, this is how everywhere we are managing, right? This is how we are managing. So sometimes it's like that, even though you are very intelligent, even though, because this is not one person's decision, it's an MDT decision, but still your diagnosis might be wrong. That's why you don't have a 100% screening test. Your CA1, your RMI is not a 100% screening. Even your visual inspection is not 100% correct. The histopathology is correct. So that's why for the chemotherapeutic treatment, medical treatment, you need a tissue biopsy. If the patient not willing for the tissue biopsy, then of course you can't do the chemotherapy as well. Chemo radiation you can't give without the tissue biopsy. So let the patient to die. 60-year-old woman who has reached menopause 10 years ago, has right-sided low abdominal pain for 1 month, abdominal pain, vaginal examination normal, abdominal and vaginal examination normal, ultrasound revealed benign features and cyst size is 5 centimeter. What is the next management? What is the next management? Yes, what is the next management? Do CA1 to 5, and again CA1 to 5 is RMI is going to be 0. So what are we going to do? We are going to review them in 6 months. If the patient is asymptomatic, repeat the scan in 6 months and repeat the CA1 to 5 in 6 months. That is the management. Unmarried woman with malignant cyst, is there any other surgical option other than THBSO? That's depend on the stage of the malignancy. If the stage of malignancy 1A1 or 1A2, you can do the unilateral salpingo-oophorectomy, unilateral, that affected malignant side, you can remove the ovarian tube and you can take the biopsy from the other side and you can do the uterine preserving surgery. But if the malignant tissues are spread to other region, even the ovarian capsule ruptured, then you can't do the uterine preserving surgery. You have to, even though she is unmarried, we have to go for a removal of uterus as well as the ovary. There is no. Is there any relations in centimeter to a period of gestation? No, it's not like that. So we are saying if the cyst size is up to umbilical region, that is related to 20-week size of period of gestation. That is how we are telling. There is no direct correlation between the cyst size and the period of gestation size. If 60-year-old patient has abdominal pain, so are we going to observe? If the patient is symptomatic, you need to do management. When the patient has symptom, you can say we'll see. That is not appropriate. If the patient is symptomatic, then we need to manage. Right? So if the patient is symptomatic, we need to manage. If the patient is asymptomatic, 5 centimeter, then we can repeat in 6 months. Okay? Any question? Okay, so the previous question, if the patient is having pain, then we need to do the surgery. I think you might understand. Is it a difficult topic, Lasandar? It's a pure gynecology
Interesting.
topic. Right?
Interesting lectures.
Yeah, but it's a difficult one. It's a pure gynecological topic. How to? So it's a guideline. Actually, I taught you based on the RCOG guideline. How we are managing.
Hello,
Can you
sir.
summarize? Yes.
So I have a question. Some of the questions are coming like the size of the ovarian cyst is more than like 15 centimeters, but they are not saying that cyst is low more than the umbilical level. It's not saying. So how we expect the laparotomy or laparoscopy in that
No.
case?
Yeah, it's you're correct. It's like that. So if they mention large is like 15 centimeter, 20 centimeter, that might reach to umbilicus. So there is
Okay.
no direct correlation, but if it is more than 15 centimeter, it's might reach to umbilical region.
Some of the questions they have taken the more than 10 to 15 centimeters, they have taken the answer as laparotomy.
Yeah. If it is up to 15 centimeter, then after 15 centimeter, it's 15 centimeter might reach to the umbilical. So there is no clear-cut correlation, but in practical,
Yeah, that's why it's very confusing when they are asking those type of questions. What we should do?
Yeah. If it is 15 centimeter, then you may have to go for a laparotomy because it might reach to umbilical region. Yeah, it's a nice question.
Thank you, sir.
Right. So if in the question, if they all right, so the same question now we discuss. So any question? I hope you might understand something, right? So last class somebody asked to do this premenopause and postmenopause. So these kind of odd topics, difficult topics, just if you have any question, you can let me know. Then I'll do like class, because in our routine theory session, so what I'm going to start by Thursday. So some students might attend to that class also. In routine theory session, we are not discussing these kind of topics, right? So we are discussing the important topics like diabetes, hypertension, labor, preterm labor, PPROM, breach. Those important topics only we are discussing. But these kind of topics, yeah, I'll explain you. We'll discuss like this, whenever I'm having free time, whenever you are having free time, we will discuss. No problem. So
I have a request, sir. If you can do ethical questions like ethics and all.
Can do, but I felt it's ethically is important for you for the clinical practice. But
Yes.
Other than the consent for surgery, for the ERPM exam, you won't get much question on ethics. But if you are preparing
last exams, I went through very difficulty because of this ethical suspect.
For the Viva?
No, the MCQ, sir. Too many ethical questions are there.
Right. So just send those questions. So then we will discuss those ethical things also. But in MRCOG, they are giving more priority for the ethical questions. So mostly they are asking about the taking consent and giving the contraceptive selection, termination of pregnancy.
Yeah.
There are so many things, right? So if you are preparing for the AMC PLAP, so then you need to know about these ethical things. Obviously, there is no question on that. But for the
ERP also now they have taken into that point.
Now the people are moving towards the Western world style, right? So
Yes.
That's a problem, really. You are correct. And another thing is, as I told you, when the ERPM is becoming competitive, right? So then they need to put the difficult questions. So then only they can limit the people. So I'm always telling to my students, please study hard, try to understand, because this ERPM is going to be a competitive, not like as your seniors told you, right? So your seniors era has gone. That era, yes, it has gone. They actually they enjoyed and they got through the exam. right? They got the question and they by chance even 35% they can pass. Now your exams are getting postponed, and you people are accumulating. That is the main problem. You need to understand that. So every time it's not possible. It's going to be like your A-level exam. So now you need to find a proper way of teaching. So proper way of studying. So without understanding, can you do the A-level exams without understanding physics, chemistry? No, it's going to be like that. So now out of 750, 300 is going to take in the so this internship. So then it's going to be competitive. So if you are not understanding that, then what you will tell, this SLMC failing most of the people. This SLMC is failing the most of the people. Yes, of course, they have to fail. Because out of 750, 800, they have to select only 300. So then 500 should fail. You need to understand that. If you have 400, out of 400, 300 pass, then yes, most of the people will pass. Out of 800, 300, if they are taking 300, then 500 should fail. Definitely 500 should fail. Now the question is, as individual, Sanjeevan should think, am I going to be in that 300? Kavinda is think, am I going to be in that 300? That's your responsibility. That is not the SLMC responsibility. Right? So you need to prepare to come in that 300, top 300. Do you understand? So then the preparation should be very much clear. Those kind of without explanation, without understanding, just memorizing, just having question, those era has gone. Those era has gone. You can't pass like this now. Sometimes you might get 45, you might get through the MCQ, but you might stuck in Viva. If you are not preparing, if you are not presenting properly, if you are not doing well, if you are not impressing the examiner, until you get 65, 70, you might not select to the internship. You might get 60 marks, doesn't matter. But you might not get into the internship. So the ERPM is going to be like that. So that's why, but what I'm telling is, most of the students, the junior students got a good chance, right? So because the Sanjeevan, Kavinda, you landed for the exam only, now you are preparing. So you might have some kind of difficulties to understand. But especially for the juniors, now they are exposed to something. Now they understand something. Anyhow, they are going to come to my class again. They come to my class again and again, 2 times, 3 times. So then when they are coming, nothing. They don't have much problem. They can simply pass the exam. Their standard is going to be higher than when I was medical student. Definitely I can say. When I was medical student, when I go final year, I know most of the students who are studying in ERPM having good knowledge than me when I was in medical student. Yeah, I know. Because now you got a chance. People are teaching you. So when I was medical student, no one taught like this. So what is RMI? We have to read, we have to find these guidelines and different books. Now you don't have that problem. So we are teaching, we are giving the notes, we are giving the book. So you have a book. So everything is in your hand. So then what else you want? Really, the local students not getting this kind of chance. So if you want, you just have a chat with the local student, how they are suffering. Because you might felt it when you are in the medical college also. The same thing. Same thing applicable here also. No one will teach, but only they will put the exam. That's it. Isn't it? So now in the existing, you are having a good chance. So please try to understand and study properly. Understand Observation Gynae. Observation Gynae is totally different subject. If you are not understanding, you can't do it. So then Observation